right, everybody. Welcome to our August regular scheduled board meeting. Appreciate staff and some public showing up. Thank you guys very much. If you have a cell phone, wonderful. If you could please put it on silent, that would be appreciated. Mr. G, are you expecting Dr. Carlson today?
I am expecting Dr. Carlson, but she's been very busy lately, so.
Okay.
Good.
With that being said, we're going to open to staff or public. If anyone has any questions, comments, concerns, we're good to go. Okay. Board has the meeting minutes from last month. Anyone have any questions or comments there? Okay. I wasn't here, so I'll stay out of the voting process there, but take a motion to accept last month's meeting.
There's three sets.
Yeah, I'll make a motion to approve the minutes from June 26th, July 3rd, and July 26th, 2019.
Okay.
Second.
Motion is second. Questions, comments, all those in favor? Four over, Cheryl.
Can I, before you approve those minutes, can I just ask a clarifying question? I did not think Dr. Carlson was able to make our last meeting. I thought it was Dr. Geary.
Yep.
And so on page 3, it refers to Jessica Carlson being present, but I could be wrong.
No.
So just pass that.
Sorry.
We would need
That's
to
too fast.
make a motion to adjust that.
I'll make a motion to approve as amended.
Those are the June minutes.
Those are for June?
June 26th.
Okay. Yeah, she was there. Okay. Thank you. July she was. Okay.
Clear?
Yes. Thank you.
Okay. Consent, everyone has had that. There's no two board members just pointing out. Take a motion on that.
Make a motion to approve the consent as presented.
I'll second that.
Motion is second. If no further discussion, all in favor? Aye.
Aye.
Okay. We will postpone med staff until Dr. Carlson is here.
Are you ready for my report?
Are you ready?
Are you that part of the meeting?
Yep.
Yeah. Sorry, thank you.
Are you ready?
Yes, I'm ready, sorry.
Just in time.
Crazy day. Every day we're like, I gotta be there before. Okay, so med staff, exciting things going on. Recruiting stuff, we should start with that. So we have 2 nurse practitioners, Sarah Dickerson. We're hoping that she's gonna be able to be credentialed by November 15th. She already has a license and a DA and all that stuff, but you know, credentialing through insurance companies is out of our control. So we're waiting for that. And then we have another nurse practitioner, Kelly Krieger, I think is how you say that, that hopefully will be starting January, which will be great. That'll really help our prime care population. Other exciting things, Dr. Michaelis is a radiologist that we've been in contact with, who can provide not only reading services for us, but also the interventional radiology procedures that we would love to have here, like CT-guided biopsies and ultrasound-guided biopsies. This could also improve our breast program, because right now some of the breast cancer cases I have to send out because I don't have a radiologist who can do localization procedures, and she could do all of those for us. She has really good general radiology experience, and so this would be such a huge asset to our place. So I'm hoping that this will work out, sort of in negotiations with her right now. Let's see, other reports. We have Dr. Davis, who's going to be out for a little while due to some health things. And we have a urologist that will be filling in for him doing some clinic, and as well as covering emergency calls. We're also in discussions with some registered dietitians, not quite medical staff news, but Curry Health Network news, which is exciting. Someone who could do some diabetes education for us, as well as work with dietary needs of inpatients. So that's exciting. Karen Morrow, a nurse practitioner that we know and love, who's been down in Brookings, who's been doing part-time for me and then a lot of prime care. She'll be switching full-time, helping my practice, starting in September. I'm very excited about this. This will take some of the current clinic burden off of me and allow me to do more procedures, which will catch up on some of our backlog after me for procedures. Other exciting things happening. I think that's about it. Jimmy, anything else that I missed?
So,
You're going to talk about patient contact center?
yeah.
Okay. I think that's it.
Good.
Any questions for me?
Keep it up.
No? Keep it up. Keep it up. Okay.
Short and sweet.
Let's say planning more surgeries.
What's that? Yeah, more surgery. I can't fit any more in this week. Not possible. We're maxing out.
Okay. Thank you. Mr. Carl?
I'm going to revert to PowerPoints. I can't help it. I can go a month or two without them, and then I start getting sweaty and hard. Anyway, income statement, start there. We had a good month. We generated a positive bottom line of $114,700. That was based on revenue, which was about 2.9% better than the budget, or above the budget. Operating expenses were 2.5% above. We like that. Revenue had a bigger variance than the budget. Revenue last year, we were 14% over last year, so we're kind of back to that growth assumption that we made when we did the budget, you remember. Otherwise, there were a couple of areas where we had some variances that warranted explanation, which we discussed with the Finance Committee yesterday. Primary one being in the salary area, we had a 10% variance. That about $100,000 of that was explained as a couple of things. First of all, unbudgeted were what we call lump sum incentive payments in lieu of rate increases when we did an evaluation of all the employees and how they were being paid compared to market at the end of the fiscal year. Some folks were, quote, redlined, meaning they were already at the very top of their market. And so we did lump sum adjustments. That turned out to be about $48,800. So that explains some of that variance. We still had about 2.7 FTEs of people on board from having gotten ready to do the Brookings ER and then held back. So they're still there. That was about $22,000. And then we had a couple of one-time annual bonuses. So that explains most of that variance. I'm not going to get into the average per month thing because we had fun talking about that yesterday, didn't we? No. Yeah.
A quick question, that is, in the hiring that you're doing right now, are you seeing additional, I know there's a $25,000 bonus up in Coos Bay that they're giving nurses and so on. Are you seeing pressure, more pressure than you thought you'd be seeing on salaries right now?
Well,
Looking over there.
I'm just going to speak from some of the numbers. We've got a number of vacant positions, whether it's short-term vacancies for great things or not so great things. I can't say that we have seen particularly nurses leaving and telling us it's because they're going somewhere else for a higher wage, but we do consistently hear that Sutter and Bay Area are paying more competitively. At our management meeting yesterday, we reinforced with those folks that have travelers or difficult to fill positions, please get with human resources so that they can start to look at how to shift those dollars from a temporary position to a more full-time and be more competitive, and how do we take into consideration our existing employees. So it continues to be an issue, but I don't know if it's just because of our salaries. I don't think that's all of it, but I'm quite certain that some of it in some arenas, yeah.
Okay. The other thing which has been a persistent issue for us is contract labor, addressing what you just said. And in the Finance Committee meeting yesterday, we said there were 16 FTEs of travelers or agency employees. It's not true, it's 13 and a half. I redid the numbers today. And the 13 and a half are 5.8 in radiology, 5.5 in the emergency room, 2 in the lab, and 0.2 for the surgery department. So 13 and a half FTEs of travelers. And Jenny, I don't know whether you or Megan want to say anything about that.
No, I mean, we know 2 of the travelers in the lab, they were brought in specifically to get micro up and running, and we didn't have labs that were qualified here to do that. We are now recruiting for full-time micro generalists with especially in microbiology. The ER situation has been an ongoing situation, and again, that's one area that we're really going to look at those wages to make sure that we're very competitive. And radiology, that is a department that we've just struggled. I mean, we have had one position, mammographer. We haven't been able to fill that position for a very, very long time, more than a year. We've had great travelers, but that's just one of those many positions that are difficult to fill. So I really don't have anything more to add.
I just might editorialize and say that is an absolute small hospital, and actually now a large hospital, problem in the healthcare industry. You know, everywhere.
You know, what is interesting, I would mention, Carl is not incorrect. Where I came from, there was a hospital in Reno, Nevada, a large medical center, and they struggled so much with nursing turnover and staffing that they actually worked to recruit nurses from the Philippines, believe it or not. So they created the work visas with them, they flew them over, they met them at the airport, they trained them, they were licensed here, and that's really how they filled their gap. So, you know, this is a real issue, it's not new either, that was happening before I came here. So, we know and we've been hearing about the workforce shortage in healthcare for many, many years. Not as many people entering it and a lot of us aging out of it. So, it's going to be, I think, a continued challenge.
Are there any other questions about the income statement? If not, I will move past this summary of the variances, which I just spoke to. And this is a picture of the income statement trend. And what we'll see here is, you know, we had 3 bad months during the last year. June was pretty good, but that was because we booked the Bergman settlement, $955,000. Otherwise, we'd had a loss that month. And July is doing pretty well. So that's what the trend looks like. The question always comes up when I show this, well, how's August going? I don't know, Jessica's still sitting here, so. Jessica, don't make August
I operated 12 hours
Okay.
straight the last 2 days, so I don't know. I'm
Well, then I can't say how August is doing.
Going well from my standpoint.
Key statistics, the yellow bands highlight the areas which are worthy of discussion. One of the things that we'll see is the average daily census was 5.4, which is down from 13% from the 12-month prior 12-month average. And question that was asked in the Finance Committee that Judy Backhouse answered was, what's one of the reasons? And that is a whole lot of observation days. Observation days were up 88%. That's an industry trend. You know, we've seen inpatient volumes consistently going down. In this case, this is one of the reasons it is an industry trend. There's an increased use of observation days, which, I don't know, Megan, you want to explain what an observation day is? You can do a better job than I do.
So the difference between inpatient and observation is just the length of stay, the expected length of stay primarily. So observation is expected to be less than 48 hours, whereas inpatient is expected to be longer than 48 hours. In short, that's the key difference.
So staffing is still going to be a function of those two added together?
The staff the same, oftentimes the treatment that they receive is the same.
but we'll get paid less, I guarantee you. That's another industry trend. Got it. Emergency services, ER visits were actually up 20%, which, when you look at the census and you look at that, you're kind of going, well, wait a minute, 90% of your inpatient visits or inpatient stays come from emergency. What happened? Well, we had a much higher transfer rate than we have in the past. So kind of contradicts the inpatient side. Anyway, ER visits up 20%. Outpatient service visits, good news, office visits up 7%. Bravo. So at least 2 practice management people sitting back there on the wall. Ancillary visits up 10%. Thank you, Sean.
I got a great team.
You do. You really do. And surgical services actually down 23%. We haven't seen that in an awfully long time. So,
Don't look at me.
that was good. Balance sheet, main focus on the balance sheet is our unrestricted funds. You all remember Medicare clawed back $855,000, which is why we had a negative month. We haven't had that in a while. And unrestricted funds, somewhere around $5 million right now, which is not so bad. That's 40 days cash on hand. So we're above our threshold. And speaking of which, this cash summary basically compares, I know it's very busy and this violates a rule of PowerPoints, but I also like full disclosure. The top rows are actual, this is the budget, this is the variance, bottom line is ending cash balance is almost $1 million over budget. So we're doing pretty well when it comes to that financial objective of building up our cash reserves. And then finally, just to close, we have our key financial ratios. The only one that doesn't show a positive green light, good job, is days cash on hand, which on a quarterly basis was down, as you just saw. On an annual basis, 3-year annual trend, we're up. So we basically hit or beat our targets on all the ratios, except for just recently on the days cash on hand, largely because of the Medicare clawback. And that's it. Then in the packet was a cash forecast, and it shows that we're tracking to end the fiscal year with about 60 days cash on hand. And this is with nothing else going on. And we'll update those forecasts as we go. This time was an 11-month forecast, not 12 as Bill would like, but it will be a Bo Schindler 12-month forecast next month. Darn right. Any questions?
I just have one. Did we ever visit the source and application funds of the old concept? Talk about it. The reason I say that is when there's other, in this particular thing here, you have a bit of, down there, if you, Carl's hidden like 27,000 columns.
Yeah, the way you get this is you take a spreadsheet and just...
Yeah, but if you look at the stuff that's in there, and you look at it, a bit of, and you take the interest out of it, and that's the money that is basically depreciation and amortization.
Right.
And it goes through your financial statement, basically is it's a non-cash thing hitting your financial statement. And we should have grown a lot more cash if you just looked straight at EBITDA than we did. Mm-hmm. And so the question is, where did the money go? And source and application would show you that. I'm just saying.
Mm-hmm. Yeah. And when you, I can tell you in the nobody's asked me about this, but in the cash projection line, I have a little note in there that says, days cash on hand on this are measured differently than days cash on hand on this. This is a formal CPA adopted definition, as you just described. You know, you take operating expenses, take out depreciation because it's a non-cash expense, blah, blah, blah. You go through that formula. It focuses on operations. On the projection that I do, I take out capital expenditures as well. And I do that because we're always spending money on capital, and I don't understand why you wouldn't consider routine capital expenditures. So that says 38 days, the trend line.
But
This is
you're off,
what-
let me see, I'll tell you how many days, if you go purely by, and you hate this, don't you, Carl?
I really do. Somebody, Karen, can you?
So I'm gonna do it.
Take that away from him.
You're off by about 15 days.
15.
Yeah, so that means,
I'm not sure what we're meaning on the law.
if you went straight off of a bid, you added that
Oh,
to
yeah,
the cash
okay,
balance.
yeah.
If you use that as the number instead of what the cash balance actually ended up being, you're off by a couple $1 million. And the source and application as a line item, it'll be like 2 or 3 of them will say, okay, part of it's here, part of it's here, part of it's here.
Yeah, we should talk about that in the finance committee, because that's are there any CPAs in the room? No. Okay, I don't have anybody I can offend. Sources and uses of funds as they're done, and it's kind of like I just said, there are accounting definitions, and then there are practical business guide definitions. Practical business guide definition is 38 days cash on hand, that's the forecast and all that. CPA's definition is 40 days cash on hand. Sources and uses would be a whole other story entirely. All I'm saying is it's a lot of arcane, esoteric information. It's required in our financials every year annually. It's also, quite frankly, it's a pain in the butt to do, and I don't know that it adds value. So, but I think we should talk about it in the finance committee.
In your cash forecast going forward, have you included all the potential clawbacks you think that the government may come back after? Or is
The
that?
ones that I know of, sure, because when we did the forecast for the budget, we had the Medicare take back in there. We had that in there. Anything else down the road that I know of?
But the better you do, the more it's going to be kind of thing too.
Yeah.
Well, we did implement the Moss Adams application for projecting month by month what the cost report will look
Right.
like. And so we will, beginning next month, start to show that. And so you speak to that more intelligently. I know where it's going to be.
Well, the answer would be that using this cost, we're going to run it every month. And we ran it for July, it really wasn't a big number. We'll run it again for August and September, because the way Medicare reimburses us is, I keep saying, for the average human being, a citizen of this country, it's like IRS taxes. If you're independent, but if you're not employed by a company, you're self-employed, you better set your money aside, you better pay your quarterlies. If you don't pay your quarterlies at the end of the year, you can owe a lot of money. Well, it's what I just described with the cost report is a very analogous situation. So you just don't want to ever owe the IRS a lot of money, and we don't want to owe Medicare a lot of money. So we're just going to measure it and pay it as we go. Make sense?
Yes.
Thank you.
Other questions? Good, Karen? All right, so I'll take a motion to accept CEO Meyer performance report.
And so moved.
Okay. Second?
Second.
Okay. No further discussion, all those in favor? Aye.
Aye.
Ms. G?
Yep, so I'd like to start out my operations report with a positive, which I was so pleased this morning. I had an opportunity to have breakfast with Congressman DeFazio and members of an invited group of folks that the congressman likes to come and listen to. It ranged from individuals representing the Port of Brookings. All 3 commissioners were there. We had the dean of SWAP was in attendance. I'm not sure if I have his title correct.
Oh, the local.
Yes. Anyway, a good showing of individuals, but what really stood out to me, very unsolicited, and after we all went around the room and talked about some of the challenges that each of our industries were experiencing that we would love some assistance from the federal government with, and after the congressman shared and gave us an update of the important things he's working on, one member, and I'm not going to disclose who it was, again, unsolicited, circled back and said, I want to share Mrs. Williams, the work that Curry Health Network is doing is being felt, and it was felt personally for him, whereby he told a story of our organization being able to meet his medical emergency and save his life. And that was all surrounding the Hoostanagan slide time. So the topic really was about the road, but it really turned the attention to how important it is that we have high-quality, life-saving healthcare here. And I don't know how many times, I couldn't count, that he just said, we have a great hospital here and we're doing great things here. So that was really nice for an individual to tell their stories without necessarily being asked or solicited. So that's my positive. Anybody else have positives they'd like to share? They go all around the room. There's other positives throughout my operations report, so I'll get to that. A few months back, maybe 4 or 5, I don't know exact time, Commissioner Gold approached the board and requested there be consideration to conduct a feasibility study around the possibility of potentially splitting beds between our facility here and a facility in Brookings. And we took that consideration, that request very seriously. And in speaking with Gary Milliman and others, it was felt that rather than spend the money on a full-blown feasibility study that would include financial feasibility and market impacts and other things of that nature, which would have been very expensive, Gary Milliman recommended that we engage the Center of Public Service from Portland State University, who he had done research with in the past, and to commission them to do a completely independent study, but looking first at the regulatory environment of critical access hospitals, and would it be feasible from a regulatory perspective to anticipate the ability to either open a hospital in the Brookings market or split beds between this facility and the facility that we operate and own on 5th Street. And so I received his report on August 7th and distributed that. So members of the public board has had an opportunity to review this in advance because it is a very, I would call it dense document. It's not light bedtime reading. But essentially, the executive summary on page 2, and this document will become public. The executive summary essentially says that it would be very difficult for a facility to be opened in Brookings. And it goes on to explain that if we try to license beds down there, it would put our critical access hospital license here in jeopardy. It would not meet requirements of a critical access facility because it is in close proximity to Sutter Coast. It further went on to talk about any facility down there that would offer an inpatient service would be required to get a certificate of need and licensing through Oregon Health Authority, and the unlikeliness that anybody would be able to demonstrate that there is a need based on the number of inpatient beds available to our size populations. And so, as I mentioned, this report is available on our website. It's part of our packet. I would like to share this with the City Council of Brookings because they've been good partners in stewardships, and obviously they have a stake in this. But I think it's, the report was, the questions have been asked and now answered.
Can you please share with the commissioners also, because they're sure they get questions from South County residents also.
Sure.
So this would help them
I will definitely
explain.
do a wide distribution, yes, and then their meeting. Any questions or
I think operational there might be a problem too. If we're getting fewer and fewer inpatient stays at the hospital, then the total number of beds that would be occupied between the two sites would be decreasing over time, which should make the operational efficiency even less going over time too. So I think there's having two complete staffs that are getting smaller, that would make it very difficult.
Yeah. Again, we wanted to just start with the first question. We didn't get into the challenges of duplicating capital and human resources, but I would imagine if you did a full study, it would show that absolutely.
My comment, of course, like in all the rest of us, we've been trying to come up with something and try to understand what the right thing to do was. And in reading this, well, first, because it's Phil Keesling, he's got his name on it. He's former Secretary of State for the state of Oregon, well respected throughout the state. It was recommended, Phil was recommended by Gary Gilman, who's a former Brookings city manager. So we basically used the Brookings advice and used somebody who was credible. And the first page, the table of contents, says it all. The reading thing is, some of it's a little hard to digest, but any relocation of beds to Brookings would likely make Curry General Hospital non-compliant as a critical access hospital, and no Brookings facility could qualify for critical access hospital. That right there by itself is almost, okay, from here it's a much start. And then the rest of it even makes it even worse. So, for me, this settles the issue as far as doing that down there.
Would we still have the option of having observation beds associated with the emergency room down there on a short-term basis?
Observation beds are considered outpatient, but I do believe it would require a licensure change anytime you're going to hold a patient beyond 23 hours. So that answers the legal question. It would require a licensure change. The second question then is the facilities equipped to handle a patient for more than 24 hours? We do not have a kitchen. We do not have laundry facilities. We don't have space that's designated for that. We definitely are aware that if and when an emergency room was erected down at CMC, that we have to have provisions to be able to treat and monitor a patient until such time as they can be safely transferred to either us or another facility. And we have taken that into account for space planning, but an observation bed beyond 23 hours is really not what we're set up to offer.
I just want to reiterate as a board member, having worked to invite Brookings to annex into the district, that we as board members were really concerned about whether it was feasible and why, or why not be feasible from an objective point of view. And for those that don't understand, critical access hospitals have to be 37 miles apart. And so that's why it would jeopardize our license to put in a satellite hospital that's, within that range of Sutter. And also, I felt, to show our heart in listening to some of the residents of Brookings who wanted to know the facts on this from an objective point of view. So I'm really glad we spent the money and time to do this.
Okay, the rest of my report you've had in writing, and I do want to mention there is a lot of work going on in the organization on our health information system. We are planning to bring our emergency room onto an emergency room platform whereby all documentation will be completed at the time of the visit directly into the computer. Currently, we work half on paper, half in the computer. Not efficient, it's not effective. And so really, the staff and management team have been fully engaged with CPSI in developing the tools that they'll use in that system. and we anticipate going live with that in about a month. I'm not going to give exact dates, I just learned my lesson on that. But we are on time and on track with that project for sure. We are also in the process of updating our system so that we can report quality metrics as required by the federal government. CPSI required us to do a pretty substantial upgrade to our system in order to allow us to continue to be compliant. The stick on the other side is if you don't report the data, you get paid less from Medicare. So it was incumbent upon us to do that. We are working with our physician providers to implement a module that they call Notes. To be honest, I don't really know what a note is. Dr. Carlson probably better does. My understanding, though, is that this platform will simplify documentation for our providers, number of screens, number of clicks, and it will also improve communication between providers. So if Dr. Carlson happened to see me yesterday and I went to go see Dr. Adams tomorrow, those notes would be readily available. So we are in the process of testing that module. We anticipate we will find glitches with that, and so it's slow going as we look at that. Another exciting process improvement project that was suggested by staff that we embraced was looking to make it easier for patients to pay in a timely manner for services and for us to actually collect co-pays and co-insurance payments at the front desk. Currently, I can collect the payment, but I have to go into multiple systems to log that payment. We're combining it, so-called, it happens to be called OnePay, where it's much like a transaction at a grocery store. I swipe my card once, everything that is uploaded and CPSI is uploaded to reflect the appropriate account. It will reduce human error and it will make us a lot more efficient, and our staff are really, really excited that we'll have that opportunity. And I know there's one other project, I'm missing it, Christina? Notes, EDIS?
Electronic prescribing control systems.
Oh, yeah, that's another big one. So I think it's in 2020, pharmacies will no longer accept prescription for controlled substances that are not electronically submitted. So the papers are going away. And so we are implementing a module of CPSI that will allow providers to prescribe electronically. So I know that will be difficult for some of our providers that choose to use paper, but I have to tell you, we are going to start taking a much harder stance. The computer has to be used. We have to get used to it, and because the world is no longer going to accept things from us otherwise. I'm sure there'll be an emergency provision, but I'm not actually sure about that. I haven't read that in legislation.
I went through this process in New York, and there was no way to do it.
No way.
No way, no, you had to do it electronically. You know, token, that you had to type your little ID and your password, and the password changed every 20 seconds. But once it was streamlined, then it was very easy and actually was so much better and much faster. Because right now, if there's a patient in Brookings that is out of a controlled substance, let's say they had surgery and they ran out of pain meds, my appointment's not for 2 days, I have to print a prescription, we have to courier it down, or the patient has to drive up here when they're in pain to pick up a prescription. So the electronic would actually make things much easier.
Is this something you have to be on site, or can you do like a phone app?
So we have access, at least I have access on my laptop to our computer system, so I would think it would streamline with CPSI.
And I think,
It's included in CPSI,
Yeah.
and you can either have a little token, or you can utilize your cell phone for the
for the special number.
Yeah, password.
So, lots of work happening on the IT systems. HB 5050, I think everybody is aware, on August 9th, the governor did sign HB 5050, and Craig Health Network was impeded for legislation to allocate $2 million to Craig Health Network in assistance to get the emergency room open. We have been working off of assumptions that money would be readily available. I can remember being told, you'll have it on the 3rd of July. Well, unfortunately, preliminary information suggests, and this does not mean this is the end of the story, but preliminary information suggests from a CPA that works on these agreements through this funding source, that funds are typically not made available to organizations awarded for approximately a year and a half, which puts us into spring of 2021. We are early and we're learning this process, so I don't want everybody to leave the room to say, we didn't get the funding, or now we're not opening anything until 2021, of which we have not established any hard date for anyway. We just have learned that it's premature for us to do a lot of budgeting and making a lot of assumptions without completely understanding what it is that we're going to be required to do from the state. And I expect we will get that letter in the agreement in the near term. He said that their final documents were before the Department of Justice, and that we could be looking for our agreement. And it included that they would include a letter essentially attesting to the fact that we would be getting those funds, so that you could carry that letter if necessary to spend the money before that time that the funds are available. So if we learn more information, we'll be sharing that with you and the public. Because again, this is very preliminary, and we really don't know exactly what it all means to us. So, so that's where we are on that. Recruitment, I think Dr. Carlson did a great job reviewing that information. On a positive note, every year we survey our employees. We call it an employee engagement survey. We started it when I was here. The Curry Health Network has done it on and off for years before my arrival, but the first survey that we conducted was in 2017, and we've done it in 2018 and just completed 2019. The results have come back very favorable. You know, for those that don't recall, 2017 was really scary and not good. 2018, we made significant strides to improve that. But 2018, we continued those strides. So this information, we're still getting the final report. We just got it back from the company that did the survey. And we will be making that information widespread to our employees, the management team, and to the board. I know the people in service subcommittee today got a glimpse of some of the data, and it just looks really good, and it just feels good to see that employees feel good. So we're really pleased with that. We did have our company picnic this last weekend. I am sorry to say I had a family emergency at 2 in the morning the night before. The morning before took me out, and I was unable to attend. But I did hear those that did attend had a really good time. I heard a rough count of about 100 employees were present. Barbecue and fun was had by all, and the weather cooperated. So we're happy that that's an event that our employees enjoy. I heard you were there, yeah.
And auxiliary.
And the auxiliary, we had a couple of auxiliary members, yes. I always include you as though you're just part of our team, so pardon me if I don't mention that.
That way you hear it.
Yes, yeah. This month, Curry Health Foundation granted our organization approximately $8,000. Our staff submitted some grant applications for some equipment that either needed replacing or that they felt would be a really good addition down our cardiopulmonary rehab. We will be replacing one bike and receiving two replacement bikes. One's a little different than the other, and an elliptical machine. And then in our laboratory, they really wanted a lab draw chair that was more ergonomically friendly for our lab techs, but also would allow us to recline a patient if they were having a vasovagal or if they were fainting on us. And so we're in the process of purchasing that equipment. And again, we thank the foundation for all of their generosity. I did attend, as Karen did too, they had a grant, what do you call that, celebration presentation? And it was really nice to see the recipients of the grants and all the great things that they do for our community. So that was fun. And then I wanted to make you aware, and I didn't include the SWAP component, but our team has been very actively engaged with OHSU and the Campus of Rural Health. They are interested. They currently have housing here in Gold Beach to house 2 students, and typically Dr. Carlson's student is the only one that's been residing there. But Coast Community Health has offered 2 modular units to be placed in Port Orford. They made that generous donation to the campus of rural health, and their thinking is that if medical students and other health professional students stayed and worked in our community between Bandon, Port Orford, and Gold Beach, that they would want to return. And so they are making housing available for 6 students. So between us and Port Orford, we'll have the capacity to house 8 students. And so OHSU, actually, members of their team came down and met with a variety of our providers to garner their interest in precepting. And so we have a number of our physicians that are very interested in precepting students. So we're hoping that we'll see additional students coming through their program. And in addition, at SWOC, a lot of work is being done with SWOC. Carolyn is working with them to see if our staff would have a reduced tuition due to them if they were Curry Health Network employees interested in healthcare career and interested in remaining in the community. And Dave Gilmore is working with SWOC on developing a curriculum for certified medical assistants. We have a tremendous need for certified MAs. While we do hire people that aren't certified, there's a big learning curve for these folks, and so we find that if they are certified, they have the basics of healthcare technology and workflow. So it would be beneficial for SWOC and beneficial for us, and I believe they're looking to offer those classes in the Brookings campus, correct?
They are.
Yeah. So that was really good news as well. And then the last thing I just included in my report was the hospital landscape. We have awarded the bid to an outfit in Port Orford. We're just working on the final details and a contract with them. So we're hoping to have that completed by the end of October. Kind of just in time for the rainy season so that things can get watered without us having to water it. And I think that's all of the topics. I'm sure there are others. That would conclude my operations report.
Kind of shocked with this about the last 4 meetings, so I'm not going to get very deep into this, and then just give us some full detail.
I don't know if you're reading my stuff.
Yeah.
No.
No, I appreciate you going through it. Anyone have a question for Jane? No, good, thank you, Jane. Okay, we're moving back on to citizen or staff input. Covered so far? No? Good? All right. Okay, board process, education. Cheryl got out a doodle poll, and looks like the third bullet point there, March 1st through 4th, everyone could attend that one. Yeah, October 1. So I guess we're going to do this. It looks like, Lori, you have the choice.
Okay?
If everyone's schedule is still available for the vote. So Laura, your choice of end of October or March?
March.
Okay, March it is.
I can
No.
Okay, so we'll move forward with that, Cheryl.
All board members.
And then, yeah.
I'm sorry, was that San Diego or?
Yes. That's the closest.
Yeah.
Closest. So that's good. Okay. That's easy enough. Strategic planning, Jenny. So when we talked last week doing the agenda, we were hoping to get some samples from these guys.
He did send me one sample, and honestly, I got it 2 days ago, and I haven't been in my office. I haven't even opened the email, so I really apologize for that.
Is that Moss Adams?
This is the Moss Adams. I think too, Bo and I had just a brief email exchange. He requested, well, how did you come to pick this group? And I explained a few reasons why I'm bringing this proposal forward in place of others that I've received in the past. The first reason is Moss Adams is, not only are they financial auditors, they provide auditing, but also they are in the realm of consulting, and they're in the healthcare sector in a very strong manner. They were recently awarded the bid from our county commissioners, so they are actually going to help Curry County with their strategic planning, and my thinking is that they will, as a team, have a very good understanding of the market and our unique characteristics, environmentally and otherwise, from that project that may be helpful or may lend to some information that we would want to consider. Brian also suggested they really didn't, in the proposal, they lacked a lot of what would typically be called your external environmental scan. So what's where, how much of it do you have, what are you missing? I did reach back out to them and they said that they could do a heavier emphasis on that portion. I've spoken to the gentleman a couple of times now. I have to tell you, he's got a lot of energy, and I did look up other strategic plans that they gave as proposal, or in a proposal to the county, but they weren't hospitals, so I specifically asked, could we see an example of a hospital? I will send that to you. In addition, I want to send you, it's a dated proposal, although I have reached out and they're still willing to work with us. There is a company called Corrigo. Maybe I'm not saying that right. Corrigo or Corgio. Their proposal was more expensive for sure. I didn't necessarily think that they would do a better job, although they have a lot of experience with healthcare in Portland, or not in Portland, in Oregon. So I want to dust that back off and have some additional conversations, and then we can make an informed decision on who we want to move forward with. I think either one will do a very good job for us.
Have you seen that, oh, sorry. Have you seen that Moss Adams has actually done strategic planning for rural critical access hospitals or not?
I did not specifically ask for rural critical access hospitals.
Or rural hospitals?
I didn't ask that. In fact, I know the example that he's sending us is for a complex health system. So I think they want to demonstrate that they can manage complexities, not necessarily small or rural. So I did not ask that.
I think, the hospital has, from my point of view, never really done a good strategic analysis of the environment. A lot of people just automatically go somewhere else. We don't know the size of that, we don't know the opportunity. So I think once we've done it, it's not something we have to go back and do all the time, but we need to at least get a stake in the ground, understanding what's available and how we want to position.
You're talking about loss revenue?
Available market versus served market. I think there's a lot of people that just automatically get in the car and drive to Eugene if they want certain kinds of procedures. And I think we need to understand that, what we could do to capture that market if we wanted to. At least what the opportunity is.
Okay, so will you get, when Moss gives you their samples, you'll get that to us?
I will. I have it in my email. I'll send it.
Okay.
Yeah, I just haven't even had a chance.
Or if they get you new ones also?
Yes.
And then are you going to send us the other proposal prior to the next board meeting too?
Yep, I'm going to send it all.
Okay.
We're going to get the Mount Saddix sample and Corrigo, and I'm going to reach out to Corrigo to see if they'll give us an example. The list of healthcare entities that I'm saying that name right, I hope I am. The organization in Portland, they've worked with a lot of health systems, but if I recall, they're pretty large. At Providence, at OHSU, they're the heavier hitters. I don't know if this is a true statement, but I imagine you will find that small critical access hospitals may not have the resources to do what we're looking to do, and so I'm not sure if that's really something we want to make sure is a criteria that they do. I don't know.
We have to have something that's appropriate. We can't have something that's too slick.
Right.
And, not only the board and the management, but everybody has to have a stake in it, and otherwise it'll be just another thing we drop
Bunch
in
of
the drawer.
jargon and semantics on a piece of paper.
And I think a bigger organization is good because they'll have a better purview of the country and where healthcare is going. I think there's going to be a lot of changes in the next 5 to 10 years. And we need somebody that's got feelers that has an idea of what's really going to happen strategically.
Okay. We got this
declaration of compliance with Oregon trauma admin rules and regulations.
Boiler stuff first.
Oh, I skipped that, sorry, go for it.
I'm sorry, where are we?
C.
Boiler service agreement, thank you. Dana has identified that we need a service agreement for the boilers in this building. And we did receive a quote for I think it was 3 years, 5 years, or 10 years. Obviously, these boilers should last us long beyond those 10 years, or I think he's quoted 12. And so his recommendation is that we sign the 10-year agreement to save ourselves some money. I would say that per board policy, I'm not able to sign contracts beyond 5 years. Otherwise, I would have not batted an eye and would have signed it. So it is before you, unfortunately, because I can't authorize.
Can you get more than one bid on that, or is it?
Nope, it's a single source. Sorry, there's not more than one bid on it. Cheryl, if I recall something, was it about $10,000 a year? I think it was.
I believe so, and over the course of 10 years, we were expected to save about $29,000. Aside the
I didn't bring
water.
that with me. I should have put the proposal in.
Is that only at the hospital, isn't there boiler down at the
There is. There's only for the hospital.
What's Perkins doing?
It's less than $10,000 a year now, but I think that is less.
Do you have it on your email?
I do.
You do, right? I know I do too. It's just my finding it.
And what do they do for that? Do they do descaling and everything to maintain the boiler?
Yes, it's all maintenance service agreement. If anything goes wrong.
Want to look at it, Ryan?
Well, just give us the
Okay.
stats.
Okay, so if it was a 3-year agreement, it would be $88.30 a year. So a total of approximately $26,000. We sign a 5-year, it's about $92.70 a year. A cost of $46,000 approximately. And if we sign 10 years, it's $10,120 per year. So initially it is more per year, but historically prices have been increasing 7% a year. So that is how they came up with saving approximately $29,000 over the course of 10 years by signing a longer-term agreement. The equipment is expected to live longer than that by far. Or invoiced.
Right?
Let's do the
total.
Yeah.
That's the total over the life of the contract.
9270 total for 5 years and
Yes.
10,000
Yes.
for 10 years.
So basically, all we're looking at is the expected 7% or more increase every year versus locking it in at this rate for 10 years.
So how long have these guys been in business?
Do you have to use somebody that's certified for hospital, or they do all
That's the
boilers?
question.
So there are other boilers, businesses with boilers around that have some?
They are the sole qualified service provider for servicing this equipment in the state of Oregon based on the manufacturer's proprietary components and software.
In the entire state of Oregon,
The entire state of
there's
Oregon.
one company that can certify boiler.
There's an opening. Yeah. Get on that, Bo.
You need a job.
Well, Jenny, I don't know anything about this, just heard, so you're good with this?
Yep.
That's
Yeah.
that's what I need to know.
And necessary evil.
And it's reasonable, I think.
Don't want it not to work.
Okay.
Yeah, if it goes down, we can't operate. Yeah, you can't. I mean, it shuts us
I
down.
make a motion to approve Jenny to sign the contract for 10 years.
Second.
Okay, we have motion second. Any further discussion? Okay, all those in favor? Aye.
Guy?
Alrighty, trauma compliance there. I don't remember doing this before. Is this an annual?
I have your signature from 2 years ago that I found. Megan, is it every 2 years?
It's every 3. Our
Every
last
3? Okay,
certification
16 was, yes.
Okay. All right. Let anyone else sign it?
You're it.
They need to authorize you to sign it, and I have the original for you to sign.
Can anybody give me a brief description of what this declaration says?
You have it.
Page 63.
Let's do this one. Here it is.
Fills out the packet.
Megan, and the trauma coordinator, fill out the packet.
Because I gave it to
So the other signers on this are going to be Trauma Service Director, which is Megan,
Trauma Services Director is actually Dr. Carlson.
Dr. Carlson. And then the Trauma Coordinator,
Is Stacy L.
and the Administrator is,
You all looked at this?
I didn't know that we had to sign this. This is news to me. That's okay.
you said it was maybe 3
We
signers.
trust the team. Megan's been through it many times.
Yeah, I don't know what.
Since I'm making motions, I'll make another motion that we approve to have this signed.
Basically, we can't get our trauma designation if we don't sign it, and we need our trauma designation.
The motion?
Make a motion to,
Your motion is a second.
There's already one.
Second.
second.
Motion second, no further discussion, all those in favor? Okay.
Are you voting on any of these things on the page?
Yes.
Okay,
I'll speak up.
it's okay.
Upcoming board meetings. So next month is scheduled here. Did we decide October for Port Orford? I don't remember.
I don't remember. It's either coming up on the calendar, I can't remember when we did it last. It's either October.
I'm gonna run into
November.
Halloween
We
there,
were supposed to go again.
if you've got kids. Yeah, we bumped up a week earlier, didn't we? Yeah,
I'm okay with that this time, so.
I am too.
So, does anyone have any conflicts for Carl McSqueal, the 23rd of October? Still gives you actually 4 weeks. October's 5-week month.
You took away my 5-week month.
Are we doing 4 or 4:30?
4. Everybody say.
But does anyone have a conflict with the 23rd?
No.
Okay.
Port Orford.
Port Orford, is that what you're saying?
Yes, please.
Where in Port Orford?
Well, to be determined.
City Hall, hopefully.
Yeah, we'll shoot for that.
And Bo, you're responsible for making sure Lori knows.
How many years do we have to pay for this? On and on.
Long memories.
Yeah, gosh, thanks.
We have to start thinking about November and December,
Oh, it's nice.
because of Thanksgiving
We
and
can do that right now if anyone would like to.
Christmas.
So in November,
Yeah, forget that.
let's see,
Carl will just move you up a week and then it's the true month there.
Thanksgiving will fall the day after our normal meeting. Okay?
Not happening.
Is Thanksgiving the 3rd?
Fourth. So it's the 28th, and our meeting is scheduled for the 27th.
Put on the 20th,
I'm gonna have a conflict.
or?
Yeah, I'm flying down to see my family. I can leave on the 27th.
No, but I mean the 20th. the meeting.
Oh, 20th, I'm fine on that.
Yeah.
Yeah.
Carl,
We can always go with that financial trade. November 20th.
Let's see what we can do.
But then, what about the city? Oh,
We'll get
the
the,
day of. What we're reading.
November's gonna move to the 20th.
Who's going to be
December the 18th.
And December, yeah, Christmas Day is our regular schedule, so the Wednesday prior is the 18th. Okay. Okay.
18th?
Yes, correct.
Okay.
Okay, all right. Maybe a quarter for next October. All right, great.
So October, November, December.
Yeah, we're starting the 3 months. Okay. Is there anything else? Good? Okay, quick meeting. All right, we are going to adjourn the public meeting here. And we are going to enter into executive session under ORS 192.6.